So I'd like to call up our next speaker, Dr. Diane Francoeur, who's also my colleague at St. Justine Hospital, Montreal. In 1987, Dr. Francoeur obtained her diploma in medicine from the University of Laval in Quebec City. Thereafter followed her internship at Hôpital Notre-Dame in Montreal and her residency training in obstetrics and gynecology at the University of Montreal. She then pursued a one-year fellowship training in pediatric and adolescent gynecology under the supervision of Professor Joseph Sanfilippo at the University of Louisville School of Medicine in Kentucky, USA. There's a very long list here that I'm supposed to read because Diane has actually accomplished many things. She is a member of many important committees in Quebec and notably of an important person at the SOGC as well. She asked me to truncate this thing and to say the major thing that she wanted me to pass on was that after all those years of training, she had never been in contact with women and bleeding disorders until she got contaminated by Dr. Georges-Etienne Rivard. Who unfortunately had to step out of the room. And she said that was the beginning of her practice in this field, and it's never stopped. So Diane, who's going to speak to us today on menorrhagia and other gynecological complications of women with bleeding disorders. Diane.
Good morning. I'm very pleased to be here. For us, it's a celebration of 20 years of meeting every Tuesday morning from 8 to 9, where one week we discuss cases, the second week we have journal clubs, and we have fun for 20 years, and I hope it's going to last as long as it can. This whole project started with Dr. Rivard and Michel David, and then Rochelle joined us, and we have a few young OBGYN in the pipeline to get rid of us old people who started the thing. So my objective this morning are to review the clinical presentation of women with inherited bleeding disorder. Obviously, from my training in pediatric adolescent gynecology, this is where we meet most of them when the periods start. We will review the bleeding disorder, which may have consequences in different periods of women's life, and discuss the pros and cons of different treatment modalities. So the first question is when? When should I see this girl, or when should you, as their healthcare provider, send them to us? And we all know that when the periods come, here comes trouble. So if you look at it from a physician perspective, my answer will be when you first buy a bra, because it's something that we've been started to do with especially Michel David at the hematology clinic. When it's time to buy a bra, it's time to see an OBGYN. Why? For many reasons. Obviously, the mother will be in severe distress when you talk about OBGYN in a 10, 11, 12-year-old girl. But obviously, we need to see them. We need to talk to them. We need to reassure them. And we absolutely need to tell them that even though on this panel this morning there was few of my patients, most of them do well. So we need to say that. We need to tell these little girls that most of the time it's going to be fine, and that probably the most important thing is where to call and where to go when it starts. And also, I thought it was interesting to have this activity where you're going to put water in pads, put Kool-Aid or Jello or whatever in it to make it red, because it always looks worse. We do that when we have an activity for OBGYN called the More OB program, where we learn all together, nurses, GP, midwives, and OBGYN, and we use a cube of Jello to estimate the blood loss. And it worked pretty well. It's fun too. So it's important that we see this girl. It's important that we tell them, because nowadays with pads, you could have only one pad that can be maybe 2-3 millimeters of blood, and you have on the other spectrum teenager who will change their pad every 15 minutes because they find it's disgusting. So you have to discuss with them what's normal and what's not. Obviously, the mother will have a different perspective regarding her own life. As we heard this morning, when the whole family has been bleeding to death every month, ever since she was told that it was normal, she may not worry about this. And if you look at it from the little girl point of view, she has absolutely no interest in seeing an OBGYN. So I just took a little case that looks like the one from Dr. Quides. Usually we get them referred by the emergency room physician. And usually the teenager will lie and tell you anything to avoid a pelvic exam. So she will say, no, 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 I don't bleed. Or mom will say, yes, 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 she does bleed. So you have to find the truth. Usually the mom will tell you the truth because she worries, especially if she has a bleeding disorder of her own. But she will tell her daughter to be brave. You know how mothers are. And usually, when they report such things like, changing your clothes, not going to sleep over at their friend's house, bringing extra clothes to go to school, this should raise a red flag. Doesn't have to be red, but at least a flag. And you should wake up and do some testing. So what's the definition of menorrhagia? It's a prolonged bleeding that is more than 7 days. And even though it doesn't look much, 80 millimeter, it doesn't look much, it's going to go more than every 21 days. What correlates of more than 80 millimeter per cycle? Soaking through one pad in every hour. I think that this is something that all nurses ask when you call the emergency room. Do you use more than one pad per hour? So it's something that is well known. Soaking through your clothes at night, because especially adolescents and all women try to avoid that. And clots that are greater than 1 inch in diameter. How common is menorrhagia? It's really common, and to unfortunately reassure all women that we had this morning, it's not that gynecologists don't believe you. They see that all day long, and you don't see patients who come to tell you, oh, everything is fine, I'm doing very well, I have no problem. Most of the time, women are bleeding, so, you're just a drop in the ocean of women who have bleeding problems. So it's important that you say things, because you're the only one who is embarrassed by speaking about blood. We speak about sex, we speak about STD, we speak about having affair with somebody else. So bleeding for us is very on the low level of being uncomfortable when you speak to an OBGYN. So causes of menorrhagia, even though it's a common presentation in teenagers, most of the time it's going to be related to a gynecologic cause. And this is what I will review with you this morning. I'll just go. Rochelle asked me to be quick, and I always listen, so I'll skip a few slides. So why is it important? It's important because sometimes there could be a severe bleeding, especially in teenagers. They bleed so much before they come to see us. It's really common. Every 2-3 months, we'll have a little girl coming from the ER with an hemoglobin of 50 or so. So it's really important that we keep them as soon as possible as they start bleeding. Treatment of bleeding problem other than menorrhagia, it's important that they know what the problem is. And I always tell medical student and resident, it's easy because, we're not, OBGYN are not known to be as intellectual as hematologists. We don't like those huge questionnaire. We have 2 questions. Soaking your bed, bringing extra clothes will get you 100% of bleeding disorder test, that's for sure. So for students, we tell, if you have a bleeding from here to the other end or surgery, this is also a concern to get prepared properly before you have your surgery. So before you do any coagulation investigation, it's important to do a complete personal and especially family history. Ask the question, do you have a sister, a cousin, an aunt who had postpartum hemorrhage after a DNC, hemorrhage after a gynecologic procedure, because it's there most of the time if you ask for it. We will complete the initial evaluation with a pelvic ultrasound, CBC, look for hypothyroidism and prolactin. We don't do pelvic exam in teenager. It's absolutely worthless. I repeat it, you don't need to do a pelvic exam in a teenager. First of all, they are so scared that their belly is gonna be like knocking on wood. You will not feel anything. And with an ultrasound, most of the time you'll find what you wanna see. So you don't need to do it. And you could use also a pictorial blood assessment chart that I'll show you a little later. So we need not to forget that adolescents are always tired. So if you ask them and try to rely on this evaluation, it's gonna be worthless. They hate blood tests, so they will lie. They will not tell you the truth to avoid blood tests. And they're not happy with what's going on. They're not happy at all. You know, it's really tough to be a teenager, and when you're different from your friends and when you have to you're put in a situation, it's not fun to soak your clothes at school. It's not fun at all. And, you know, we always say that kids are nice. It's not true. Adolescents are not nice at all. Everybody make fun of them and tease them and no. And I was surprised because I have 2 teenager boys. And one day one was in grade 5 and he said, "Do you know that in my class there are 5 girls who have period?" And I said, "How do you know that?" So, you know, they make fun of everybody, of normal things. So just imagine what's going on when you're not like the rest of the class. So this is an example of the pictorial blood assessment chart that we ask the women to fill before they come to see us. It gives us an idea. So who should be screened? We already discussed a few of these things. I would just recommend and emphasize that it's really, really, really important that we test before we consider any surgical treatment. And as a surgeon, I would recommend, if you have any doubt, test them, because, you know, these women bleed. These women bleed. They are the worst I had. But, we used to, now with our recommendation for prophylaxis of thrombosis, we give a lot of heparin. So if you miss a bleeding disorder before you do a major surgery, you're gonna be in trouble after the surgery. You should also consider the use of DDAVP or other blood replacement product and be ready that it may bleed. Bleeding symptoms in von Willebrand disease, menorrhagia is going to be by far the most common presentation. The rest, we already heard of it. Other clinical presentation, postpartum hemorrhage, any post-gynecologic surgery procedure, post-DNC, ovarian cysts, and it's well known that women with von Willebrand disease or other bleeding disorder are more likely to have endometriosis as well. We discussed that. So the importance of seeing a little girl before they get their first period is that, you know, when they have a bleeding disorder that is known, the trouble is there. And we have to, and the study shows us that the number needs to be addressed specifically. Now, we discussed already that with Dr. James, so I'll skip it. Okay, how to treat menorrhagia in women with bleeding disorder. Approach differ a little between women with or without a bleeding disorder, except that you will not wait until it goes very bad to change your approach treatment. Even though it's always interesting that women with bleeding disorder will say, "I'm not allowed to use NSAID," we use it for dysmenorrhea on a short period, just before the period start. It's okay, we always check with the hematologist and they always say yes, and it helps little girls who have very intense periods, so they can use it, it's okay. But obviously we will not use it on a prolonged basis. DDAVP and factor replacement therapy should be reserved for severe cases when nothing else works. Factor replacement therapy should be avoided unless around surgery. And we try to avoid surgery as much as we can, because all of us who've been doing surgery in women with bleeding disorder, it's always more complicated than in other women. So we try to save it for the last treatment option. So these are guidelines that have been done with the SOGC in, it's about maybe close to 10 years now, there will be revised, and this is a good side effect of the partnership between the Canadian Hemophilia Society and SOGC, because guidelines are spread all over. They are accessible to nurses, physicians, midwives, all the people who see women on the front line. And we also hope that we're going to be able to find funding to do something interactive for little girls. We have a site called mysexuality.ca, yeah, and because I use it in French, and it's been used very much in school to teach young people about sexuality, STD, but we would like to have a part of it about what's normal and what's not when you have your period. So speaking about treatment approach, you could use hormonal and non-hormonal method. In Canada, mothers are also afraid of birth control pills, but since it's our best treatment approach for most of the little girls and it will change their life, we push a lot on it, and usually we are able to convince the mother that it's not an opening to have sexual intercourse. We use a lot of Mirena, which is an intrauterine device that releases hormone. We've been using that for many years. When I was the president of the Association of OBGYN in Quebec, we made it clear 10 years ago that it had to be paid by the public health system, and when as a women OBGYN you are convinced on an idea that is good for women, we did a lot of lobby and it's been very successful, and there's really difference in the use of the Mirena in Quebec compared to the rest of Canada because it's very expensive. It costs $400, but it changed women's lives, so it was quite easy to convince them. And this is why we do probably less and less surgery in women with bleeding disorder, because it works so well. We use the Mirena even in little girls. Just after menarche, the uterus is already normal size and is able to receive it when we need it. And obviously, you put that under sedation. Otherwise, you will never see them again. But this is something that works very well. You can also use non-hormonal when the bleeding is not that severe, like we use a lot of antifibrinolytics product. We don't use as much DDAVP because one of the concerns is that you need to buy a full box, and it's for us it's easier to use cyclocapron, so this is mostly what we use. And the treatment approach will be different. It depends on the bleeding, because what I learned after those 20 years is that, just like Dr. James said, it's not the hematology the problem. It's usually the GYN that it is. And you know, most of the time when menarche starts naturally, everything goes well. Even in women with Landsman, they don't bleed to death the first period, all of them. But if you have PCOS, or if you have irregular bleeding or anorexia or any other kind of health problem that you may see in teenagers, then they start to bleed and they never stop. So we use sometimes just cyclic progesterone for 10 days just to make sure that they don't skip too many months when the bleeding is not that intense. We use OC, patch, ring. Ring is not popular in young teenager. It's more in older teenager. It's all the same thing. It's a pill in a ring or pill in a patch. It's exactly the same thing. It's hormone. We used to use 50 microgram of estrogen in most of the time. It's not available anymore, so it's important that you just prescribe more if you need it. And this is probably the question my patients were asked most often was, how old is your doctor? Because when we treat these teenagers, we use huge amount of estrogen to stop the bleeding, and pharmacists are sometimes a little suspicious that we know that low-dose birth control pill exists. You can use Depo-Provera. It works well as well, but the problem is that when you have a severe bleeding disorder, you need to have a good nurse. You know that because it's an IM injection if you miss it. then you're going to have more than just a little bruise. So OC spatch or ring will decrease the bleeding by 50%, and it's important to convince the parents. Most of the time it's the mother, but we see more and more father. It's good. And we need to convince them that it's important that they do that for their daughter, because sometimes they don't realize, or they're obsessed by this bleeding problem, and to be able to do gym or to go over to friends will change their life and their general attitude. We try to use more monophasic products because it's easier to, if you start bleeding and you're away, just to take 2, 3, you can take up to 4. And we try to avoid the 20 microgram because most of the time it's not going to be enough. I already talked about the Mirena. It works very well. It's been, in fact, I don't know why I did this lobby, because it's the enemy of the OBGYN. Since the Mirena is there, we don't do a hysterectomy anymore. So I probably lost a few friends with that, but anyway. Depo-Provera, we spoke about it. I'll skip this part because somebody else will cover it. We had an interesting case maybe 2 years ago that I'll just share with you. We will publish it at our next pediatric adolescent meeting. We had a little girl who had a huge clot. She was maybe 13, and she had received a huge amount of cyclopropyl, and she made a really big clot that was like 8 by 10 centimeter that was not going out of the uterus, and it looks really funny on the ultrasound. We thought she had a huge tumor or whatever. We're ready for the worst, but finally it was just a clot. So this is very uncommon, but we didn't think it could exist, but it did. So we just did a DNC and removed it. And I'll skip that too, DDAVP. Now, I just want, we already discussed about the risk of bleeding with a DNC, and this is for my colleague, primary care or OBGYN that are not used to women with bleeding disorder. It's a new trend to give misoprostol to women to expel the retained product of conception when they have a miscarriage. But it's a real danger for women with bleeding disorder to let them go home with misoprostol and bleed to death alone at their house. So it's really, 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 really important that this message go through, because they could bleed very much and maybe on their own at their house and not be able to come to the hospital. It's important, we just said that when the bleeding comes sometimes because of GYN reason, there are mainly 2. Infection that usually comes 2 weeks after, 10 to 14 days after, and retain of a product of conception. And this is why you need to tell the women before she goes home after a DNC, make sure that if you start bleeding or the bleeding increase in 2-3 weeks, that you come back to see us. So I'll skip this part. So despite prophylaxis, women will bleed, even though we do our best. We try to be the best team. They still bleed. Why? Because, you know, if you look at these, there must be a pointer somewhere. Yeah. If you look at this procedure, if you're not an OBGYN, it looks like terrible, but it's not that bad. But you can easily see that it may bleed. You know, we use all kind of device. We scrape the cervix with, here it's a Q-tip, but now we use a brush. If you have a bleeding disorder, you're going to bleed 1 week after you have a pap smear. When we do colposcopy, we take biopsy of the cervix. So obviously, if you have a bleeding disorder, you need to be prepared before, even though it's just a test that is done at the clinic. And this is why it's so important that women get empowered and they just tell your doctor, oh, don't forget, I need to be prepared. And they say, yes, yes, I was ready to write the prescription. If you have a biopsy, we call it a cold knife biopsy for precancerous cell, obviously we cut in big vessels, so you will bleed again. And when you do a DNC, you just scrape the lining of the uterus. It's full of vessel all around, so just a little DNC can make you bleed for 6 weeks when you have let's say, a factor 7 deficiency or a Glanzmann or any kind of other procedure. So the next step that we see these women is usually what we call middle life crisis, and I call it life is too hard. So when you get divorced or your kids are sick or you lose your job, you will be stressed and you will have an ovulatory cycle, and then the bleeding starts again. So it's important for these women that you repeat the investigation, because it's not because they have a bleeding disorder that they won't have nothing else, so they can have fibroma, precancer cell of the endometrium. So after 35 years of age, we usually do a biopsy with preparation. You need to do also an ultrasound that will show you these. I took a bad one just to impress you, because we don't see these things. So obviously, if you have a fibroma inside the uterus, you can easily imagine that you're going to bleed, because the lining, the endometrium, will not be able to be as regular as usual. And obviously, you need to fix that to be able to stop the bleeding. So we need to rule out hyperplasia. We know that the risk will be increased body mass index, and unfortunately, it's a disease that is growing. If you have a family history, you could have fibromas, adenomyosis, endometriosis, and you can have tumor of the ovary, but those are rare. Treatment option, it's really interesting to see that women have a different perspective of having a hysterectomy. Some will call it losing my uterus, especially when they were not able to have children or were planning to have more than they could. And for some of them, it's going to be, hallelujah, I got my life back. But it needs to be done at the end when we tried everything else, because even though it's going to be a relief surgery, it's still a surgery that can have a lot of complication, and those women are really afraid to die, and sometimes we are afraid that they may die too. So it's really important that we try everything else before we do the hysterectomy. We don't do much endometrial ablation anymore in Quebec, because the Mirena does exactly the same thing. So it's important that we try this option before. So I'll go quickly. So the take-home messages: menorrhagia is common. Screening for underlying bleeding disorder is appropriate. We need to try hormonal and non-hormonal, and sometimes both of them, to decrease the bleeding. We need to prepare them appropriately before we do the surgery. And our goal is that women with bleeding disorder should be allowed not only to buy white pants, but to wear them. Thank you.
Thank you very much, Dr. Francoeur, for that wonderful presentation. Unfortunately, we're not going to have time for questions, but because we're going to run into lunchtime, Dr. Francoeur will be available to answer any questions, and we'll have plenty of time to readdress many of those issues in the afternoon in the multidisciplinary panel. Thank you very much. So I'd like to call on our next speaker, before I lose my sheets, Dr. Sue Robinson, who will speak to us on iron deficiency anemia. Dr. Sue Robinson is a hematologist at the QE2 Health Science Center with a busy clinical practice. Since she started practice, she's been director of the Provincial Adult Bleeding Disorder Clinic. She's a professor at Dalhousie University and has been program director of the Hematology Residency Program. She's involved in research, being the local principal investigator for a number of bleeding and thrombosis studies, most recently co-investigator for developing a new study for women with bleeding disorders funded by the Canadian Hemophilia Society. She has served on a number of national committees, including being president of the Association of Hemophiliac Clinic Directors of Canada, and is now a member of the Women and Bleeding Disorder Subcommittee of the Hemophilia Clinic Directors of Canada. So I welcome Sue to talk to us on this very important subject.
Thank you, Rochelle and Claire and the Planning Committee. It's a real honor to be asked to speak. I've got this for my stress and my color. And so I'm going to talk about iron deficiency. More and more I'm seeing women with this. So they're my objectives. And I'm just going to present a case, a 36-year-old woman with known von Willebrand's disease, heavy periods from menarche, on and off iron over the years, always tired, doesn't get her blood work done very often. She usually stops the supplements because she gets constipated, and she might feel a little bit better. Had 2 pregnancies, was given just low-dose Materna, and more recently her periods were very heavy. She had more fatigue, lightheadedness, shortness of breath, and was having problems concentrating at work. And her hemoglobin was 76, low end of normal 120, and her ferritin was 2, low end of normal 10. So that's a picture of our bodies. We have about 2 to 4 grams of iron in our bodies. We're very efficient at holding on to that iron, and we only absorb a little bit, 1 milligram per day, so you can eat all your steak and clams and broccoli, but we will only absorb a little bit, and then we will lose about 1 milligram a day. But you can see at the bottom there with our periods, we'll lose up to just under 1 gram, but up to 10 milligrams per day might be the loss with periods. And the body is very efficient. As I mentioned, most of the iron is in the red blood cells. I'm not sure where the pointer is, but the red blood cells stay in circulation for about, stay in circulation for about 3 months, and then the iron will be recouped in the liver, and there's a very efficient system getting that iron back into the red cells. And then more recently, there's been a couple of very important proteins, hepcidin and ferroportin, and I don't need to go back on that, but they regulate the absorption of the iron through the GI tract. So anemia is very prevalent in a third of the world's population. So that's about 2 to 3 billion people have anemia, and most of that, the majority, are iron deficient. Especially in women and children, is iron deficiency a problem. So 12% of non-pregnant women of reproductive age have iron deficiency anemia, and up to 25% of pregnant women will have iron deficiency anemia, and it may well be more than that. Certainly more than that is iron deficiency without anemia, and up to about 40% or more of women will have that problem. And in developing countries, the deficiency without the anemia may be 2 to 5 fold higher. And how can anemia affect you? Well, we've heard some things about quality of life, and that's very prominent. There's a number of scoring systems that have shown iron deficiency to really affect quality of life, physical performance, ability to work. We heard one of the speakers earlier talk about the problems trying to cope with work, and reduced growth and development in children particularly, and there's some evidence to suggest that you're more prone to infections. And some common symptoms, some women don't have any symptoms. Some women have just lived with their iron deficiency since menarche, and they don't really recognize what's going on. But lots of those symptoms you'll see there. Restless legs, sometimes it's not recognized, but I see a lot of women with that. Hair loss and nail changes. So here's some of the cognitive issues. Headaches, very common with iron deficiency. Reduced memory, can't concentrate, irritability. Some of the husbands or partners may be aware of that. Depression is commonly seen in deficiency, and you may not recognize that that was a contributing factor until it's resolved. Pica is that unusual craving. It's not that common, I don't think, but when you see it, it's really interesting. So the pagophagia is the ice craving, and the geophagia is the dirt craving, and some women really have that. And there's quite a bit of literature about iron deficiency and poor pregnancy outcomes. And there's similar literature, but not as much, with iron deficiency without the anemia. Causes of iron deficiency, going through the childhood years of growth and development, a poor diet, so watch the the vegetarians that aren't getting enough iron. We've talked about the menstrual loss, chronic blood loss. One thing that's not mentioned there are the marathon runners, the big-time runners that can lose blood. This is a very important group. I've got another slide. Decreased iron absorption, either from celiac disease, Helicobacter pylori infections, or autoimmune gastritis. And here was a recent study looking at women with iron deficiency, anemia, or just the iron deficiency, and almost 70% had menorrhagia, no surprise. So they all had to undergo upper endoscopy and have stools for occult blood. And if the stools were positive, they had colonoscopy. And 2/3 of them had some pathology that suggested they may have some malabsorption of their iron. So a number had Helicobacter pylori gastritis, 16% had celiac disease, and 7% had the gastritis. So lab testing, so we use the hemoglobin, and there is that range, 120 to 160. So lots of people will say, well, your hemoglobin's 118 or 120, don't worry about it, but you're still iron deficient. 40% of patients with iron deficiency anemia will have normal red cell volume. Typically, iron deficiency is associated with small red cells, but that might not always be the case. There's been a number of studies to show that ferritin is the best biochemical test we have for iron deficiency. And if you do the other tests, the serum iron and TIBC percent saturation, that's probably wasting some money. But the ferritin itself is a fairly expensive test. It's about $20 a test. And there's the normal range again. And just a reminder that the ferritin measures the iron, but the iron, it's also measuring a carrier protein, and that protein can go up with acute phase reactants, and just like with inflammation, it's an acute phase reactant, just like we heard about the von Willebrand factor and the factor 8. It may be higher with inflammation. So definition of iron deficiency, the ferritin, usually it's referred to as being less than 15, but more recent publications are looking at less than 30. And if you use less than 30, that increases the sensitivity and specificity that of finding these patients who are truly iron deficient. And this is just a cartoon showing the importance of measuring ferritin. So here's the your body's iron stores, and this is normal, this is depletion of iron, this is deficiency. So if you're just looking at hemoglobins, it's going to be quite late in the game that you're going to drop your hemoglobin. This would be looking at serum iron in the plasma, and it doesn't drop till later on. But if you're looking at ferritin, which is the best test to reflect total body iron stores, that's going to fall early, and if you follow that, you're going to prevent the anemia. So recommended dietary iron intake is 8 milligrams, and again, you only absorb about 1 milligram a day, so you're only going to absorb a fraction of that, more so with menstruating females, and especially in pregnancy. And you might not be able to see all these very well, but heme iron is absorbed much better than non-heme, and there's your red meat, and there's your clams. And so this is the cartoon. The guy says that he doesn't like spinach, and the point is that it probably, don't really make yourself miserable eating your liver and your meat if you're not a meat lover, because your body's only going to absorb a little bit more through the GI tract if you are iron deficient. It'll increase it from about absorbing 5 to 10% of what you ingest up to about 15 to 25%. So diet alone isn't going to make it. If you're iron deficient, you have to use supplements unless your cause of your iron deficiency is just temporary. So there's what's on the market. There's lots of different names, but ferrous sulfate, gluconate, or fumarate are the common ones. They cause a lot of GI symptoms in many patients. The lucky people tolerate them well. But constipation and upset stomach are really quite common. This is the polysaccharide iron, better absorbed. You can take it with food or not with food, and less GI complications. And here's the elemental iron, gluconate, sulfate, and fumarate. So it just keeps getting better, but may cause the GI symptoms. And there's your Ferromax, which has the highest elemental iron. And there's your Proferin, which has been recommended by some, but it doesn't have a lot of elemental iron. There's the cost. Unfortunately, the insurance companies will not pay for these, which is a crime, I think. So there's ferrosulfate, just cents, and then it just keeps getting more expensive. Ferrous fumarate's fairly expensive, and there's your Ferromax, 60 to 70 for 3 months supply, cheapest at Costco. And then, so if you've got a patient, they're not absorbing these well, and they can't afford maybe the Ferromax, you might just make sure that they're not taking some other medications with it, like avoid the antacids. And Pam, don't drink your wine when you're taking your iron supplement, and don't take your tea or coffee at the same time. You might try vitamin C, but really the literature with that, it might improve some dietary iron, but it may not help. Take separate doses instead of one if you are taking more than one a day. Better absorbed on this empty stomach, except for the Ferromax is on both. And there are some film-coated, some liquid ones that are better absorbed. There was recently a Cochrane review that looked at taking supplements once a week, twice a week, 3 times a week. So don't give up if you're getting the GI symptoms. Maybe you could take one and then see how you're doing a week later and just take them once a week. And this did show that there was some improvement of hemoglobin and ferritin, and it's worth giving that a try. So once you start your iron supplements, just remember to I would suggest keep following your hemoglobin and that ferritin. And you want to get the ferritin up near the upper end of normal. If you're not tolerating the iron, maybe you could just see what's acceptable with matching symptoms and levels. If you've got ongoing periods and no other cause of iron deficiency is found, maybe it's time to go see gynae. And if you've got light periods or stop your periods, obviously, if you still have iron deficiency, you need to see the GI consultants. Parenteral iron, it's a great solution if you can't tolerate oral iron. I would not recommend the intramuscular injections. They're painful. They stain the skin. Most people do not know how to give them, so the absorption is limited. And if you've got a bleeding disorder, it's not a good option. So in terms of what we worry about the IV forms, the anaphylactic or the serious reactions, they are very rare. So with the dextran, it's 3.3 per million, and the iron sucrose is 0.6 per million. There's recently been a publication giving IV iron dextran over an hour. In these patients, it was almost 400 patients getting a gram over an hour, and a very small percent, 6%, had some side effects, but only one patient stopped the infusions altogether because of hives. I haven't tried this, but I think it would be worth a try. So our patient, hemoglobin was 76 and ferritin 2, so within about 8 weeks, her hemoglobin was 136. And her ferritin was 200, and she felt better than she had for years. And now she is able to tolerate her, she's able to take Ferromax and tolerate it. Just a word about pregnancies. We know the iron demands are higher with pregnancy. There are a number of recommendations for giving women iron supplements during pregnancy, but they do differ. In the U.S., it's 30 milligrams a day. For WHO, it's 60 milligrams a day, up to 120 milligrams a day. In Europe, it's only in the second half of pregnancy. In the UK, it's only if the ferritin's less than 30, and only patients they consider at risk would be tested in the first place. So recently there was a study looking at over 2,000 women, and in the antenatal period, similar to what I said before, about 25% were iron deficient, and that's using ferritin less than 15, and only 10% had a ferritin checked at their first pregnancy visit, and up to 53% had low ferritins. And then the next step was a lot of these patients did not get treated once it was identified that they actually had iron deficiency anemia. So I do urge you to be proactive and just check that you are getting your blood tested, know your levels, and make sure you are getting replaced. And this is a Cochrane review recently of looking at iron deficiency in pregnancy, which just looked at women getting either oral supplements, intramuscular or IV. Most of these centers were from low-income countries, but there really wasn't any data to say that it is effective and that it doesn't cause side effects. So the conclusion is that iron deficiency with or without anemia is very common in menstruating women and pregnant women, especially common in women with bleeding disorders. Certainly can affect quality of life. Important to get that blood work checked. Make sure you've been screened for other causes such as celiac disease, Helicobacter pylori are common ones. Treat it, obviously, with the most effective and best absorbed supplement. If you can't, if it doesn't work with the oral, then you should go up to the IV. And obviously, as I've mentioned, follow-up blood work is very important. And I'll stop there.